Assalamu alaikum. I am Dr. Muhammad Abu Safia. Today it's my pleasure and honor to introduce today's distinguished speaker, Dr. Sameh Galal, consultant pediatric ophthalmology and Strabismus and Research Institute of Ophthalmology in Egypt. Today, Dr. Sameh will be presenting a lecture on the three-step test, Bart's Bielschowsky Three-Step Test, one of the most fundamental and clinical tool for diagnosing vertical strabismus and identifying paretic extraocular muscles. This lecture promises to provide practical insight that will enhance our understanding and improve our clinical decision-making in the management of the complex strabismus cases. The lecture will be in English, and after that, the discussion will be in Arabic. Please join me in giving a warm welcome to Dr. Sameh Galal.
Thank you, Dr. Muhammad, and thank you, Dr. Abdurrahman, for giving me this opportunity to share some very few pieces of experience about some clinical tests. Because I love this lecture of having three-step tests to understand, because many people, and allow me to fly back maybe 22 years ago when I started reading about three-step test. So I asked myself a question: why should we go for this test for assessment of vertical strabismus? Because if you understand well the anatomy of extraocular muscles, so you can check each muscle separately. So like when you test the lateral rectus, just check for abduction, if it's working well or not. You'll know, is it properly working or paretic or paralytic? The same works for medial rectus. And for superior rectus, it's okay to check in elevation and abduction. It will give you an idea about the function. And the same works for other vertical and oblique muscles. But before explaining or verifying the causes of the importance of the three-step test, let me check some very few basic anatomical considerations about the extraocular muscles. Because if we try to, again, to know the basic balance of the extraocular muscles, you'll find we have 4 cycloverticals. And for the term cycloverticals, it means vertical recti and oblique muscles. So each eye has 4 cyclovertical muscles: one superior rectus, inferior rectus, superior oblique, and inferior oblique. So each one of these muscles is working with balance with another one, or with functioning with balance with another function or action of another muscle. So if you have the elevator superior rectus, you have the depressor inferior rectus. If you told me the superior rectus is intorting the eye, I'll tell you the inferior rectus is extorting the eye. If both superior and inferior recti are adductors, so you'll find the superior and the inferior obliques are abductors. So each one has its action, and another one is doing an antagonistic action. So when we look straight forward in the primary position, you'll find your eyes are balanced in normal situations. So it will not be elevated in one eye other than the other one if you don't have any dysfunction. It will not be depressed in one eye. So they will be properly working. The same works when you look in different directions of the gaze, because if you are looking to the different directions, you have 9 positions. The first one, we told you just a few seconds about it, the primary position. So you have 8 muscles working at the same time to keep the balance in the primary position. The 4 vertical recti, 2 in each eye, and the 4 obliques, 2 in each eye. But if you look to the right gaze, what will happen? You will have abducted eye by the action of lateral rectus, and the adducted contralateral eye with medial rectus function. And you know well about the direction of action of each muscle. So if you are looking straight up, you have 4 working muscles: superior rectus and the inferior oblique in one eye, and superior rectus and the inferior oblique in the other one. But what happens if you are looking upright? If you are looking upright, you'll find only 1 elevator in each eye, because the abducted eye will be elevated by the effect of the superior rectus, and the other one will be elevated by the inferior oblique, which will elevate the eye in adducted position. So I don't like to take much of your time, because I know you know well the anatomical action of each muscle separately. But what happens if you have one weak or paretic or paralyzed muscle? You have to know what's called consequences of weakness or paralysis. So let's explain what's happening in vertical position, but to make it much more simple, we have to know what's happening in horizontal paretic muscles. Like that case with sixth nerve palsy. If you have unilateral sixth nerve palsy, what will happen to this eye? It will be abducted with failure of abduction, and this is what we all know. But what are the anatomical backgrounds or anatomical adaptive mechanisms that will try to solve this problem with abducted eye with failure of abduction? Usually we have weakness of the affected muscle, and goes without thinking. If you have sixth nerve palsy, so the lateral rectus is not working well. So there is failure of abduction. This is the first consequence of have paresis of the sixth nerve. The second one will be overaction of its direct antagonist, which is the right medial rectus. The medial rectus will take upper hand on the balance in the primary position. So the right eye in primary position will be adducted. So first we have failure of abduction, then overaction of the direct antagonist of the right eye, which is the medial rectus. So what will happen? The eye will be isotropic, as you all know. So sixth nerve palsy usually present with either abnormal head posture or right esotropia. Then the brain is trying to do its best to motivate the paretic muscle. So it sends much more innervation to the paralyzed muscle to make it working. And by hearing low, the same innervation power will come to the other eye, to the medial rectus. So what will happen? The lateral rectus will receive much more innervation, but it will not be translated into action. So still we have failure or diminution of abduction of the right eye. And on the other side, the medial rectus is perfectly well. So it will receive the same neutral amount of over-innervation to the medial rectus under the effect of the hearing low. So it will be much more abducted. So the third consequence will be over-innervation and overaction of the contralateral medial rectus, which is called the yoke muscle. Yoke muscle is the muscle in the other eye that will do the same action when that muscle works. So the yoke muscle of the right lateral rectus will be the left medial rectus. Right lateral rectus and the left medial rectus are called yoke muscles. So more innervation will come to the yoke muscle that will be translated into overaction of the yoke muscle. But again, the right eye is still isotropic. So what will happen? Some inhibitory impulses will be sent to the contralateral lateral rectus, which is called the contralateral antagonist. So again, there will be weakness of the contralateral lateral rectus. So simply when you have paretic or paralyzed right lateral rectus, you will have failure of abduction, overaction of ipsilateral adduction, overaction of contralateral adduction, and inhibition of the contralateral abduction, which will be translated into failure of abduction of the other eye with the intact sixth nerve, but it will receive inhibitory impulses, which is called inhibitory impulses to contralateral antagonist. So what if we didn't treat this patient? If it's left untreated for a long time, what will happen? Overaction of the direct antagonist may be translated into contracture or overaction. The other yoke muscle again will be overacting or may go for contracture. And the left lateral rectus will be much weaker and it may have prolonged weakness if you don't treat at the proper time. Again, if we went back to translate this for vertical strabismus, it will be much more complicated. Because if you looked at this child with right over left eye, and if you are thinking basically, we can call it left hypotropia because the right eye is normally looking in the straight position and the left eye is depressed. So we can call it left hypotropia. But what will happen if we check the other directions? You'll find this patient has right superior oblique palsy or fourth nerve palsy. But why it came with the right normal eye and the left hypotropic? Because the right eye was the dominant one. So it was depressed to fix centrally, and the other one was depressed accordingly by hearing low. So now we call it right over left, not left hypertropia. So right over left or left over right may be affection of the higher or lower eye. We don't know unless we have proper approach to detect which muscle was primarily affected to be translated. So again, the first rule of understanding the balance of extraocular muscles is to know each muscle has an action, and on the other hand, we have an antagonistic action to that action. So what will happen if we looked right and left? This is rule number 2. If you looked right, the right eye will be abducted and the left one will be adducted. So in the abducted position, why don't you have elevated or depressed eye? If you are intending to look right, why this eye is not going up or down? Because at this place you have a single elevator, which is the superior rectus, and a single depressor, which is the inferior rectus. So in abducted position, if you have intact the superior and the inferior recti, the eye will not elevate or depress because both of them are intact, working in balance, so no one will take an upper hand. The same works for the left eye. It's in adducted position. So in adducted position, we have single elevator, which is the inferior oblique, and single depressor, which is the superior oblique. So in the right gaze, the right eye is not going up or down because the balanced action between the superior and the inferior recti, and the left eye is not going either up or down because of having intact inferior and superior recti. The same works for the left gaze. This is rule number 2. So rule number 1 is we have balanced all extraocular muscles. Number 2, in abduction or adduction, we have one elevator and one depressor. If both are intact, we can have straightly adducted or abducted eye without being elevated or depressed. Let's go for rule number 3. What will happen if you tilted your head? Because if you are going with your head to the right side, what will happen? The right eye now wants to keep the intact primary position. Look. So what will happen? It will turn or be rotated to the antagonistic direction. So if the right of the head was tilted to the right, the left eye has to tilt to the left side, and the right eye will tilt or rotate to the left side. And the right eye, it will be called intorsion, but on the left side, it will be called extorsion. So both eyes will be rotated left, but for left eye, it will be rotated out, which is extorsion, and the right one will be rotated in, which is called intorsion. Vice versa, if you went to the left head tilt, you will have right eye rotating out, which is extorsion, and the left eye will be rotated in, which is intorsion. So if you return it back to know, if you tilted your head to the right eye has to be intorted, and we have two intorters, superior rectus and inferior oblique. And the left eye has to be extorted, and you have two extorters, the inferior oblique and the inferior rectus. The same if you tilted your head to the left side. What will happen? The right one will be extorted by the inferior rectus and the inferior oblique, while the left eye will be intorted by the superior rectus and the superior oblique. But if you looked again, what is the relation between the superior rectus and superior oblique? They are both intorters. So what are the other actions you know about them? The right eye will be intorted by the effect of the superior rectus and superior oblique, but the superior rectus is elevator and superior oblique is depressor. So the right eye will be intorted by the superior rectus, which will cause intorsion and elevation, and will be intorted by the superior oblique, which is causing intorsion and depression. So the mere effect will be intorsion by two actions, superior rectus and inferior oblique, and the effect of elevation of the superior rectus will be neutralizing the depression effect of the superior oblique. So the eye will be intorted without causing elevation or depression, because one of them is elevating well with intorsion, and the other one is depressing well with intorsion, so the eye will be only intorted. The same action is for the extorted eye. If you are rotating the right eye out, what will happen? It will be extorted by the inferior rectus, which is extorter depressor, and will be extorted by the extorter elevator inferior oblique. So again, if you are rotating your eye to either sides, the eye will be rotated to the other side without being elevated or depressed. I remind you again, this is guarded by the effect of the functioning normal vertical and oblique muscles. So what if we have any abnormality of these muscles? If you have abnormal superior rectus, superior oblique, inferior rectus, inferior oblique, one of them is affected. What will happen to the eye? In normal situations, when you are looking straight ahead, both eyes are vertically aligned. So no one is elevated or depressed. But if you look at the image on your left hand, what's going on? We have right eye higher than the left one. And the image on the left side will show you the higher left eye than the right one. So we can't tell at this picture we have right hypertropia or right left hypertropia. I don't know. So just what we call we have equal vertical position of the right and left eyes, or we have right over left or left over right. So what's happening when you are describing a vertical strabismus? So the first take-home message from today is, please, when you are describing a vertical strabismus, don't tell it's hypotropia or hypertropia. Just tell which eye is higher, so right over left or left over right. Let's go again for logic thinking. What if you have right eye than the other? So if you have right higher eye, right over left, you have one of four options. One of the elevators is affected, which is the right superior rectus, or sorry, one of the depressors of the right will be affected, which is the right inferior rectus or right superior oblique, or one of the elevators of the left side is affected, which is left superior rectus or left inferior oblique. Again, if you have higher left eye, what is the problem? The problem may be in the depressors of the left eye or elevators of the right eye. At this point, with this simple picture, I can tell, regardless my experience is, to whichever extent you are experienced in strabismus at this picture, you can never tell which muscle is affected, but you can tell well which eye is higher than the other one. But again, you can't tell which eye is abnormal. You can't tell which muscle is affected. So we have to take a help from any other place. So putting our three rules that we mentioned in the start, if we have right over left, how can we think? First, we have to put our four options, either the right inferior rectus or right superior oblique, which are the depressors, or the left superior rectus or inferior oblique, which are the elevators of the left eye. At this point, I have four muscles to accuse or to think about, or to suspect which one is affected. So what we do is to compare which eye will be, or the right over left will be higher in which direction of the horizontal gaze. If you looked at the right side and left side, try to compare. Right over left will be worsened or be improved. So again, if you looked at this picture, right over left is worsened in the left gaze, while it's almost disappearing on the right gaze. Even if it didn't disappear, it may be improving. And to compare, we have worsened right over left in the left gaze. So now it's much more clearer, because if you think about now, the right gaze showing normally aligned eyes. So the pressure of the right eye in abduction is normal. And the elevator of the left eye in abduction is normal. So you don't suspect anything about two muscles. And we have two muscles to accuse. So we have normal right inferior rectus, and we have normal left inferior oblique. And you have only two muscles to think about. Either the depressor of the right eye in left gaze, which is the right superior oblique, or the elevator of the left eye in abduction, which is the left superior rectus. So out of four, we have only two now to think about. I'll just put a very, very nice tip after having the second step of three-step test, because you came out with two muscles to think about out of four. But just to verify you are going on the right way, the two accused muscles, one of them is right and the other one is left. Both of them are superior. You can't get out of the second step with one superior and the other inferior. One of them is oblique and the other one is rectus. So let's put again, we have right and left, oblique and rectus, and both are superiors. So after the second step, we have only two muscles, one right and one left. Both are superiors, one oblique and one rectus. But again, at this point, I can't differentiate which one is the paretic or paralyzed one. It is the right superior oblique or the left superior rectus. So we have to jump to the test number 3. We have to put the head in right head tilt and to repeat it again in the left head tilt. So what will happen? It will be worsened on right head tilt. So now the right eye, when trying to intort, it's intorted only by the superior rectus because of the paralyzed superior oblique. Superior rectus will cause intorsion and elevation, while the other side will be extorted by left inferior rectus and left inferior oblique, which are not accused at all. So now, if it's worsened on the right side, right head tilt, so it's only the superior oblique muscle. So let's summarize case number 1. Right over left. So we have 4 muscles. Right over left, which is worsened on the left gaze. So it's either the right superior oblique or left superior rectus. It's worsened more on right head tilt, so it's only right superior oblique. Let's go for case number 2 to make it maybe much clearer. Now again, right over left. So we have right inferior rectus, right superior oblique, left superior rectus, left inferior oblique. The same as the last case. Let's go for second step to know which 2 can be got out from this test. So again, it's worsened in the left side. So again, I can suspect the right superior oblique or left superior rectus. So still, I can't know which one. Is it the right superior oblique or left superior rectus? Let's repeat the head tilt test, but this time it's much more worsened when you tilt the head to the left side. At this part of the head tilt, what will happen? Because the left head tilt will make the right eye be intorted. And in this case, we have intact normal superior oblique. So the right eye will be, extorted. It will be extorted by the inferior rectus and inferior oblique, which are normal, while the left eye will try to intort. And this time it will be intorted by the superior oblique, which is the intortor depressor. Why it will fail to compensate by intorsion elevation by the superior rectus. So if we have right over left, which is worsened on the left gaze, and left head tilt, it is left superior rectus paresis. Scenario number 3, we have right over left. We have 4 muscles, the same 4 muscles. But this time, right over left was worsened on the right gaze. So let's think again. We have 2 different options. Because at this situation, we may have affected right inferior rectus, which is the depressor in abduction. So it's the depressor and abduction of the right eye. Or we may have the elevator of the left eye in adduction. So what I can get out is either the right inferior rectus or left inferior oblique. But before leaving this step, I can verify again. One of them is right, the other one is left. Both are inferior. One is oblique, the other one is rectus. So after getting step 2, we suspect now the right inferior rectus and the left inferior oblique. What will differentiate between both? Head tilt. And before going to the third step, you have to ask yourself, what will happen normally in head tilt? The eye at the side of the tilt will be obliged to intort, and the other one will extort. So now, When we tilt your head to the right side, what will happen? Both eyes will be rotated left, which is called extorsion of the left eye and intorsion of the right eye. And now it's worsened when we have left head tilt. This means the extorter of the right eye in left head tilt is affected. What's the extorter of the right eye? Extorter of the right eye in left head tilt is the inferior rectus. So now we have inferior rectus paresis, which is presented with right over left in primary position, worsened with right gaze horizontal position, worsened with left head tilt. That is right inferior rectus. Last option of right over left. When we have right over left, again, the same four muscles. Right inferior rectus, right superior oblique, left superior rectus, left inferior oblique. To differentiate, we have to go for right and left positions. It's worsened on the right gaze, like the last one. So we have only two muscles to suspect, right inferior rectus, left inferior oblique. But this time it's worsened on right head tilt. So on right head tilt, what will happen? The right eye is obliged to intort by the normal superior rectus and superior oblique, while the left eye is obliged to extort by the left inferior rectus. But unfortunately, the left inferior oblique failed to do compensatory extorsion and elevation. So this accounts for the worsened position on right head tilt. So for left inferior oblique palsy, we have right over left, worsened on right gaze, and much more worsened on right head tilt. For those who didn't catch it well, let's reverse to understand more. Now we are coming with left over right. What will happen if you have left over right? So you think about the depressors of the left eye or elevators of the right one. So you suspect now the right superior rectus, right inferior oblique, or left inferior rectus or left superior oblique. Flying to step number 2. Now it's worsened on right gaze. So left over right worsened on the right gaze. So I can suspect now right superior rectus or left superior oblique. And I think you are much more smarter now to understand both are superiors, one right and one left, one rectus and one oblique. Step number 3, it was worsened on left head tilt. So it's left superior oblique paresis. Just to remember, in superior oblique palsy, what is the abnormal head posture the patient takes is contralateral head tilt, like that image on your left hand, because he's just keeping the affected muscle out of context. He wants just to discard the action of the paralyzed eye. He didn't want to use. So on right head tilt, actually, either I have normal or abnormal left superior oblique I am not using at this point. So the patient will take abnormal head posture of right head tilt. Summarizing the left superior oblique palsy, it's left over right, worsened on right gaze, and left head tilt. Being more faster, left over right, four muscles to suspect, but now it's worsened on right gaze. What will happen? I'm suspecting right superior rectus or left superior oblique. So again, it's much more worsened on right head tilt. So this is right superior rectus paresis because the right eye, which has the superior rectus affection, now failed to intort and elevate. So what happened is intorsion and depression by the intact right superior oblique. Now, the left eye is not rotated in abnormal position with a vertical correlation because it has both extorters are normal. So in right superior rectus palsy, we have left over right, worsened on right gaze, improving on left gaze, worsened on right head tilt, improving with left head tilt. What about scenario number 3? Left over right, that is worsened in left gaze. So now I'm suspecting affection of the left inferior rectus or right inferior oblique. So to differentiate, right head tilt, it will show worsening of the left over right, but will improve on left head tilt. So this is clear left inferior rectus palsy. Because on right head tilt, the eye has to be extorted, and the extorted depressor is affected. So the extorsion will only be happening with left inferior oblique that will cause extorsion and elevation. So in left inferior rectus palsy, it will be left over right, worsened on left gaze, and right head tilt. Last scenario, if you have left over right that worsens on the left side, now you have either the left inferior rectus or right inferior oblique, but this time it was worsened on left head tilt. So this is clear right inferior oblique paresis, because at the left head tilt, the inferior oblique of the right eye has to extort and elevate, but it failed to do that. So extorsion happened only with the intact extortor depressor, which is the right inferior rectus, that make it much worse on left head tilt. So in right inferior oblique palsy, we have left over right, worsened on the left gaze, and left head tilt. Case number 9, and I think you are astonished now because we don't have a ninth muscle to suspect. But scenario number 9, I think we have a different approach done by some people. I don't like this approach, but just to tell you what's happening in some scenarios or some clinical schools. When they have vertical strabismus, right over left, like that one, they have exchanged the step number 2 and 3. So now you have 4 muscles to suspect. They fly to step 3 in our approach. So now they have right over left that worsens on right gaze, right head tilt, and improves with left head tilt. So now you suspect either the right superior oblique or left inferior oblique. And they verify the action by the 3rd step, which was the 2nd step in our approach. I don't like to make it much more difficult, but just to put in your mind, if you want to this, it's not wrong. It's one of the correct maneuvers some people are doing. If you are not doing, don't disturb your mind thinking much about it. And thank you very much.